Hello everyone, welcome to the Academy of Online Radiology Education. My name is Sara Momtazmanesh and I'm a postdoctoral research fellow in the Department of Radiology at Johns Hopkins University. I'm truly excited to be here and to contribute to the ACORE blog series. In today's blog, we are going to talk about imaging-derived adiposity phenotypes and brain health. I'm very grateful to my senior editors, Dr. Gozzi and Dr. El-Sayes, and thank them for their valuable help and support during the preparation of this presentation. We are going to talk about a compelling new study from the January 2026 issue of the Radiology Journal. This article, titled Association of Body Fat Distribution Patterns at MRI with Brain Structure, Cognition, and Neurologic Diseases, examines how MRI-derived fat distribution patterns relate to brain structure, cognitive performance, and neurologic conditions. The concept of the body composition brain axis has gained tremendous attention lately. Unlike prior studies that relied mainly on BMI, this work uses MRI to directly characterize regional fat depots, which provides a more precise and biologically meaningful assessment of adiposity. Adiposity is defined as accumulation of body fat and is a key marker of cardiometabolic health. A growing body of evidence indicates that obesity and adiposity are linked to structural brain changes, cognitive decline, and accelerated neurodegeneration. In fact, neuroimaging investigations have shown that greater total fat is associated with decreased gray matter volume in specific regions, increased white matter lesion burden, and disrupted neural networks. Interestingly, these effects appear to be different by sex. For instance, one study showed that men showed gray matter loss across multiple regions such as globus pallidus, thalamus, caudate, and hippocampus, while women showed prominent changes primarily in the globus pallidus. In addition to the structural changes, adiposity may also increase the risk of neurologic diseases such as dementia and stroke, as well as psychiatric conditions such as depression and anxiety. Moreover, recent studies have suggested that visceral fat is associated with greater Alzheimer's disease-related brain changes rather than subcutaneous fat. Therefore, the location of adiposity is also important. The sex-specific patterns were also observed for subcutaneous fat, with even possible modest protective effects in women. Most prior studies relied on crude overall adiposity measures, such as BMI or waist-to-hip ratio or DEXA scans. However, fat stored in specific organs, for instance liver, pancreas, muscle, or visceral, shows distinct associations with brain health. Therefore, MRI enables precise quantification across multiple depots. This supports this study's focus on MRI-based body fat distribution patterns. This cross-sectional study was conducted using data from the UK Biobank cohort, a large and well-characterized population-based dataset. The final sample included nearly 26,000 participants with a mean age of 55 years, and the cohort was predominantly of white ethnicity. All participants underwent standardized MRI of the brain, heart, and abdomen. In the statistical models, the investigators adjusted for a comprehensive set of covariates, including age, BMI, ethnicity, income, education level, smoking status, alcohol consumption, hypertension, diabetes, dyslipidemia, and physical activity. In the first stage, the authors aimed to describe body fat distribution patterns through latent profile analysis, or LPA, applying it to BMI-adjusted MRI-derived fat depots stratified by sex. In the next stage, they investigated how these patterns related to three main outcome domains, including brain structure, cognition, and neurologic diseases. For brain structure, they assessed volumetric measures as well as white matter metrics from neurite orientation, dispersion, and density imaging, and the brain age gap. Particularly, the brain age gap is a novel metric developed in the UK Biobank, reflecting the difference between a deep learning-derived biological brain age and chronological age. For the cognition domain, they evaluated psychomotor speed, memory domains including prospective, visual, and working memory, verbal and numeric reasoning, and global cognitive score. And lastly, for neurological diseases, they incorporated ICD-coded diagnoses such as dementia, mood disorders, stroke, epilepsy, and Parkinson's. Before diving into the results, let's break down the method they use to identify these fat distribution patterns. Latent profile analysis, or LPA, is a method for uncovering hidden subgroups. It looks at the entire combination of traits all at once rather than examining just one variable at a time. In this study, we had 8 fat measurements from MRI: liver, pancreas, pericardial fat, and so on. The question is whether natural clusters emerge from the overall pattern across all of these 8. That's exactly what LPA does. It's data-driven, so we don't specify how many groups there should be. Instead, we test different models with multiple profiles, and the algorithm determines which number of groups fits the data best. After we select the optimal model, each participant is assigned to the profile they most resemble based on probability. Crucially, all 8 variables are considered at once. That means each profile reflects the person's entire fat distribution pattern and not just one depot. In this study, the LPA identified 6 distinct profiles in both men and women, and we'll explore those next. In this slide, you see 6 distinct adiposity profiles derived from the data. Profile 1 was characterized by pancreas predominant high adiposity, meaning these individuals had a notably elevated pancreatic proton density fat fraction, or PDFF. PDFF is an MRI-based measure of fat content expressed as the ratio of fat signal to total signal. Profile 2 was hepatocyte predominant high adiposity with very high liver PDFF. Profile 3 was the skinny fat group. In fact, these individuals had elevated visceral adiposity and a higher fat-to-muscle ratio, yet a normal BMI. Profile 4 was balanced, but with high adiposity across depots, and Profile 5 was balanced with lower adiposity. Finally, Profile 6 served as a reference group. These individuals had low fat in all depots and were lean overall. I have highlighted profiles 1 and 3 because they illustrate 2 distinct fat distribution phenotypes that show particularly notable associations with the study outcomes, which we will discuss later. Starting with gray matter and global volume, profile 1, the pancreatic predominant pattern, and 3, the skinny fat profile, showed the most pronounced gray matter atrophy. Profile 1 demonstrated substantial effects in both sexes, whereas profile 3 showed stronger associations in men. More broadly, cortical atrophy was observed across profiles 1 through 5, particularly in the prefrontal and temporal lobes. For white matter outcomes, white matter hyperintensity volume was increased across profiles 1 to 5, with the largest effect in profile 1. Diffusion metrics indicated microstructural disruption, primarily in men with lower neurite density and higher free water fraction in profiles 1 to 3, while women showed minimal differences across most fiber bundles. Finally, accelerated brain aging was observed in men across profiles 1 through 4, whereas no significant differences in brain age gap were detected in women. Turning to cognitive performance, psychomotor speed, prospective memory, and visual memory appeared most sensitive to differences in fat distribution patterns. A clear male-specific vulnerability was observed in the skinny fat profile, or profile 3, across multiple cognitive domains. In contrast, reduced global cognitive score was observed only in women with the pancreatic predominant profile. With respect to neurological disease risk, mood disorders, including anxiety and depression, were consistently more common across high adiposity profiles in both sexes. A stroke risk was increased in men with a skinny fat profile and in women with a pancreatic predominant profile, suggesting sex-dependent patterns. Additionally, epilepsy risk was elevated in women with the pancreatic predominant profile, further supporting sex-specific associations. Overall, the cognitive and clinical outcomes mirror the imaging findings with distinct sex-dependent patterns across adiposity phenotypes. The key takeaway is that the pancreatic predominant and skinny fat profiles represent the highest risk adiposity phenotypes for brain atrophy, adverse white matter changes, cognitive vulnerability, and neurological diseases, and this is independent of BMI. Importantly, many individuals in the skinny fat group had only moderate BMI. This challenges BMI as the primary metric for brain health risk, particularly in men. The findings also highlight clear sex-specific effects. Men appeared more vulnerable in the skinny fat profile, whereas women showed stronger associations in the pancreatic predominant profile. Finally, given the cross-sectional design, these results reflect associations and should not be interpreted as causal. Thank you very much for your time and attention, as well as to the Academy of Online Radiology Education for this opportunity.